Diaphysis. Fracture of the diaphysis occurring around 5 centimeters distal to the lesser trochanter. Where is the lesser trochanter situated? Around the head of the femur, and 5 centimeters proximal to the adductor tubercle at the distal femur. The femoral shaft is fracture is circumferentially padded with large muscles, which helps in improved healing, faster healing, good vasculature, and resistant to trauma. Disadvantages: difficult reduction due to muscular forces. So what are the causes of this shaft of femur fractures? Mainly high energy trauma, that is road traffic accidents, fall from height, or high speed accidents. Can also be low trivial injuries, which occurs mostly in elderly, that is the low energy, or pathological and stress fractures. What are the associated conditions in which shaft of femur fractures can occur? Can occur in ipsilateral femoral neck fractures. What is ipsilateral? Single side. It can occur in bilateral femur fractures, single side tibial shaft fractures, same side acetabular fractures, or fractures associated with thoracic or abdominal injury. Classification is not important. Coming on to the clinical features. Clinical features involve two things, that is the symptoms and signs. What are signs? What is symptoms? Symptoms is something that the patient explains. Signs, what the doctor sees or evaluates. So the symptoms will be pain, swelling, mainly over the thigh. There might be bleeding or bruising over the thigh region. That is, discoloration will be present, bluish discoloration. The patient will not be able to bear weight, and there will be deformity or change in the attitude of the limb. On the signs that are seen here, on inspection, it will be tense, there will be swollen thigh. The blood loss at this place of fracture will be around, next class, will be around 750 to 150 ml, 1500 ml, and it is double in open fractures. यहाँ पे खड़े हो जाओ फिर. The attitude is due to the deforming forces of the musculature around the femur. The attitude is something that we see the patient position the patient comes in. What are the deforming forces? It will be because of the muscle pull. Fragments, they will be flexed, abduction of the proximal fragment. The distal fragment will be adduction and in extension. This is the deformity that is seen. So how do we evaluate or treat the patient? What is the ATLS procedure? ATLS protocol. What do we follow? What is A? B? C? D? E? So here we follow the ATLS protocol. We provide adequate fluid resuscitation, in which we maintain a normal vital signs, that is the heart rate is maintained at around 100 beats per minute, systolic BP at 100, बैठो कहीं आगे ही बैठ जाना, more than 100, diastolic at 70, and the patient should have an adequate urine output of around 0.5 to 1. वहाँ पे चले, वो मोबाइल पे खेल रहा है ना, उसके बगल में बैठ जाना. This is followed by X-rays are done in these patients. What are the X-rays that can be done in a shaft of femur fracture? What are the main X-rays that are done? In which view? AP and lateral view. So AP and lateral view of the same hip. We get the hip X-ray, either in PBH, pelvic with both hip, in AP view. Along with that, the same side X-rays are done in shaft of femur fracture, that is the AP and the lateral view. We always consider during X-rays, we consider a joint above and a joint below. So in this case, we can also get a knee X-ray. How do we manage this patient? If the patient is non-operative management is required, we first and foremost we apply a splint. This is the most common splint, and it is asked in every exam. A splint separately, that is the Thomas splint. First used by Hug Owen Thomas. It has a ring that is present above at this region, and it has a bend over here that is around 120 degrees. It comes on the outer side, there is a bend, and the inner side is at the lower side. The ring is obliquely placed and a lower side. It is on the groin region, and this is until the greater tubercle, greater trochanter. Sorry. So the Thomas splint is mainly for temporary stabilization of fractures. Along with this, we apply also a skin traction. This here seen is a skin traction that is applied over along with padding until the heel, and traction is applied here. As you can see, this traction is applied for applying weight on the opposite side along with counter traction. Once traction applied, deformity is corrected. How do you apply? How do we know the size of the Thomas splint? We take the circumference of the thigh. The circumference of the thigh region around add 5 to 6 centimeters to accommodate the swelling. And the length of the Thomas splint is maintained by from the groin to heel region, and we add 15 to 25 centimeters to allow plantar flexion of the foot. Along with this, we can also apply this was the part of the skin traction. Along with this, we can apply skeletal traction. Skeletal traction is something in which you apply a pin either at the distal femur or the proximal tibia, and traction is applied along with weights. The next step is the operative step, in which we apply intramedullary nailing. This is the gold standard technique if in closed fractures. In open fractures, what do we do? Apply any idea in open fractures what can we apply? External fixator. This is the external fixator as seen in the X-ray images, AP and the lateral view. Thank you. We can also perform an open reduction internal fixation with plating in these cases. So in this case, we can see how a patient is managed. If the patient is an unstable patient, unstable as in, besides femur fracture, patient also has other complications like respiratory, heart failure. Then we perform an external fixator for temporary stabilization. After stabilization, we perform the intramedullary nailing. If a stable patient is present only with a simple shaft of femur fracture, a simple IM nailing is done. If complications, open fracture is present, we perform external fixation. And if other complications in which open fracture after application of external fixator is done, we perform a plating. Open reduction internal fixation with plating. The complications that we can mainly see here: shock, fat embolism, acute respiratory distress syndrome, heterotrophic ossification, pudendal nerve injury, malunion and rotational malalignment, and delayed union. Next topic here is fat embolism. So what is fat embolism? Fat embolism refers to the dislodgement from one place to another, dislodgement and presence of fat globules in the vital organs and peripheral circulation after fracture of the long bone. When there is a fracture of the long bone, in simple terms, when the fracture of the long bone, from one place there is an embolism, it goes to another place through the blood circulation and the vital organs are affected. It is a systemic manifestation as a consequence of this emboli. Most common causes are, when you write an answer, mainly focus on definition, causes, clinical features, and then the management, investigations and treatment. So the causes here will be multiple fractures of the lower limb during operative procedure of intramedullary kneeling, during hip and knee arthroplasty, that is joint replacement. This mainly occurs when the fat globule is more than 10 mm. It is not commonly seen in the pediatric age group. In fat embolism, a common tride is present, tride meaning 3 parts. That is, the respiratory symptoms will be present, that is dyspnea or tachypnea. Neurological symptoms, patient will be in confusion and disorientation. And the third will be petechial rashes. Conjunctiva, over the conjunctiva, axilla, neck, umbilical region or chest. 3 classical triad. Also present under fat embolism is the GERDS triad, GERDS criteria, in which it will be 1 major and 4 minor. Headings are important, in which major will be the axillary or subconjunctival petechiae, that is the spots. The oxygen will be below 60 PaO2 level, on EBG will be 60 mm Hg. There will be CNS depression, that is confusion. Pulmonary edema will be present. These are the 4 major criteria, of which one should be major, 1 major and 4 minor. Minor, tachycardia, fever, anemia, thrombocytopenia, flat globules in sputum, fat globules in urine, raised ESR, full form, and retinal emboli. How do we prevent this? We prevent it by fracture stabilization. How do we perform fracture stabilization? What is the splint? Thomas splint. Either by Thomas splint or within, if the patient is going to operate within 24 hours, we perform a external fixator. We remove the fat emboli from the circulation by starting a lipolytic agent, that is heparin or hypotonic glucose. We also decrease the systemic response, that is with dextran and aptrotitin. What can fat embolism cause further? In simple terms, blockage at the heart, blockage over the lungs mainly. What is the main aim of treatment here is adequate oxygen supplementation. Oxygen is the only therapeutic tool, positive pressure ventilation if required, and we maintain a target oxygen level of more than 40%. If required, steroid use can also use to prevent or regress O2 toxicity.